So this video continues my neuro-ophthalmology series, and we're going to look at optic tract lesions, or more specifically post-chiasmatic optic tracts, which makes reference to the fact that the optic nerve, or the pre-chiasmatic optic tract, is not actually a nerve at all, but part of the central nervous system. If you haven't looked at them already, then it may be worthwhile going back and having a look at these two videos. The first is explaining all of the pathways and the testing that we do, and the second is looking at localizing to the retina or the optic nerve. You can find those on my YouTube channel. In summary, those two lectures were basically taking you through the first part of localizing lesions, which is first of all to determine can they see, and we use several tests to assess that. An ophthalmological examination to look at whether or not the eye is normal, to determine if the pupils react normally to the light, and for that we use a papillary light reflex, assessing a direct and consensual reflex, and often using a swinging flashlight test. The caveat with that is that you must use a bright light and be cautious that you're not being fooled by iris atrophy, where there is a deficiency of the iris muscle, or fear, where the dog has influence of the sympathetic nervous system and a more dilated pupil. And then you need to look at whether or not there are any other neurological deficits. And when we're looking at vision, we're particularly interested in other deficits that would localize to the forebrain, because of course most of the visual pathway is in the forebrain. And we're also interested in whether or not there are multifocal deficits. And in this lecture, we're particularly going to look at deficits of the optic tract, which is a difficult area. And in fact, in most veterinary textbooks, you find very little on the optic tract. And in fact, in the one that I most commonly use, which is Della Hunter, it actually says that these lesions are so rare that you're very unlikely to see them. But actually, that is not my experience. I'm going to share with you one case, and I would say when I see optic tract lesions, they're usually the same disease as this dog has. So a quick reminder of the visual pathways. We have this diagram, which is representing the papillary light reflex, that is saying the reflex of the iris diameter to light, and so that involves the retina, the optic nerve, relays through the rostral colliculus down to the parasympathetic nerve nucleus of the ocular motor nerve, and you get a reflex constriction of the pupil. And because of decussation, when you shine light in one eye, you will get a consensual reflex in the other eye. The commonality of those pathways is the optic nerve, the chiasm, and the optic tract. And at that point, most of the fibers, about 80% of the fibers, go off to the visual cortex. So they go up through the thalamus and up to the visual cortex. However, a minority of them, about 20%, maybe less, go off to do that papillary light reflex, and also the other reflexes associated with turning the head in response to a visual stimulus, which is mediated through the pretectal nucleus. So those visual pathways go from the optic nerve, which is just in this area here, you can just see it coming out here, to the optic chiasm, and then go up in through the optic tract, which is difficult to point out just in an MRI scan because it is traveling up through this region, and so at this particular slice it is there just before it gets to the lateral geniculate body of the thalamus, and then from there it goes into the caudal internal capsule, the so-called optic radiation, which then goes to the occipital cortex here. So with the optic tract, as I've said before, about 80% of the optic tract goes to that lateral geniculate body of the thalamus, and then on to the visual cortex, and the remaining goes to the pretectal nucleus and the PLR, and then the rostral colliculus, which is mediates those visual reflex, the eye-head movement in response to in reflex to sudden movement in the visual field. And I'd really like to recommend this rather marvellous paper, I absolutely love it, which is published in Frontiers in Neuroanatomy, the neuroanatomy reconstruction of the canine visual pathway using diffusion tensor imaging. And I love this because it's so difficult to know exactly where that optic tract, optic radiation is going through, and they used diffusion tensor imaging, which basically looks at the water molecules in a fibre, in particular the direction that they're going. So they're able to pick out bundles of fibres of nerves, and you can see the way these pathways are going. And what this is showing here is the optic nerve, and then you can see the decussation at the optic tract, optic chiasm, then it goes through to the optic tract, and then we can see it coming back through here to mediate the PLR and the turning of the head in response to visual stimuli. And we can also see it going up through here, the internal capsule, as I've said before, and the optic radiation. And there's many lovely images in that paper, and I really recommend that you read it, and thanks to the authors for doing that study. So one concept that I need to introduce at this time is that of vision, visual fields, and decussation. Now, the amount of decussation at the optic chiasm varies with the species and depending on how much binocular vision you have. So humans and primates with excellent binocular vision have 50% decussation, but dogs and cats with better peripheral vision have 75% decussation in the dog and 65% decussation in the cat. Now, what this will affect is your visual fields and how they are perceived in the brain. So if we talk about this right-sided visual field, so everything coming from the right here, then when it hits the right eye, it will hit the nasal temporal field, and when it hits the left eye, it hits the temporal visual field. Now, the temporal visual field is not decussating, and the nasal temporal field is decussating. So it means that all of the fibres in this bundle are generally coming from the same area of the visual field. And of course the opposite is true. And so these fibres here are decussating, and this area of the retinal field is not decussating. So this is an important concept to remember when we're looking at blindness in the dog and the cat. So if we have a lesion here of the optic nerve, then we're stopping all fibres coming through from that right eye, and therefore this animal will be completely blind on the right, but will have normal vision on the left. However, if we look at a lesion right in the centre of the optic chiasm, and this is quite a selective lesion, I have to say. I'm not sure that this happens very often in real life, but theoretically we can have the images coming through from the nasal temporal, nasal visual fields here, and here, which is very, very narrow in the dog and cat, which means that they will have a very small amount of vision just in that nasal temporal field, just because these fibres aren't decussating. Whereas when we look at an optic tract or a forebrain lesion going right the way up to the visual cortex, what we'll have is that most of those fibres there are coming from the decussated fibres from the left eye. And so essentially the animal will be almost completely blind on the left. Whereas they will be visual on the right, because most of the fibres from the right eye will have decussated and going up to the contralateral visual cortex. However, there'll be a very, very small deficit on the nasal field. In practical terms, in the dog, it is very, very difficult to be able to confirm that they have that very small amount of sight in that nasal field, and I'll show you why in the case that we're going to look at later. In the cat, because there is less decussation, you may well be more likely to be able to detect that they have vision in the nasal field and have lost it on the opposite side. So to all intents and purposes in the dog, if we have a lesion which is of the optic tract and above in the visual cortex, then the clinical effect of that will be blindness in the contralateral eye. I hope that makes sense. It's one of those things that you often need to stare at for quite a lot before you can get your head round it, and that's what I recommend. Take some more time. So we're going to now look at our case. So this is a 2-year-old male Yorkshire Terrier, and he was presented with acute onset circling. Now I have a whole YouTube video on circling, and we're not going to go into how to differentiate different types of circling here because it would just make far too long a session. I'm going to show you it once again, and we can see that it's a very tight circle and that he's walking with pretty good coordination really, despite that tight circle. Here is his visual and light reflex testing. That was me whistling there because this dog is very obtunded and it was difficult to get his attention. So I'm just dropping cotton wool ball there, and we want to see whether or not he reacts to it. There is our menace response. Palpebral. Menace response, palpebral. We're checking that the facial nerve is intact and the dog can in fact close his eyes. Let's look at this again, as I'm sure you want to. Can you see it when it's dropped on his right? Can you see it when it's dropped on his left? Menace response. Now, if you were assessing the nasal and temporal fields, of course, you would want to be coming in from different directions. But when a dog is obtunded and twisted like this, I think you can agree that it's very difficult to do that. I'll leave you to draw your conclusions from that one, and we're just going to look at the pupillary light reflex. So here we have the pupillary light reflex on the right. Remember what you decided on the vision for that? So I hope you can see that when there is a light is shone into the right eye, that there was a good constriction, but when I go across to the left eye, the pupil is actually dilating. So this is an abnormal swinging flashlight test. What did you think of his sight? Well, to me, he had a menace response and was tracking on the right, which is the same side as he has a pupillary light reflex. But he wasn't tracking, and he didn't have a menace response on the left, which is where we have an abnormal swinging flashlight test. So what does that mean? So now we're going to look at the postural responses in this dog. Here is our hopping test. What's the difference between the right side and the left side? Here we go again. I think we can agree he's much worse on the right side compared to the left side. So now we need to put that all together. We need to localize the lesion. So what do we think? And I've put you the choices here, and I've also put our diagram up to help you look at those different lesions. Is it the right forebrain, the left forebrain, right brainstem, left brainstem, right optic nerve, left optic nerve, right optic tract, left optic tract, or is it multifocal? What do you think? And there's more than one right answer here, it should be said. This is a difficult case to interpret, which is one of the reasons why we're doing it. So this is what I had: right forebrain and right optic tract. But it didn't all fit together. I couldn't explain the right postural deficits with that, and so my ultimate conclusion was that this was multifocal. Let's go back to that right optic tract and the flashing light, swinging flashlight test. So what we saw was that the dog was visual on the right, but non-visual on the left. And we saw that there was a normal PLR on the right, but when we swung the light over to the left, then the pupil dilated. So what does that mean? Well, if it's not visual, then there must be a lesion somewhere. If it's not visual on the left, there must be a lesion somewhere in that pathway. And given what I've said before about the visual fields, then this makes it likely to be here, 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 or going off to the visual cortex. Then we had the abnormal swinging flashlight test. So when we've shone light in on the right side, then we know that this works. So it works coming here, it works crossing, it works going here and crossing over to the left because the pupil did constrict. There was a consensual when we shone in the right, and also it works this way and constricts there. But when we went over to the left, the pupil dilated as if there wasn't any light coming in there. So that meant there must be a lesion here, here, or here, because we know that everywhere else works. So it could be a lesion of the left optic nerve, or potentially a lesion of the right optic tract, which is much rarer. Now, why did I say right optic tract and was more likely? Mainly because right forebrain. I've said that, so that fits together more easily. Why? Let's go through the clinical reasoning for that case, and I'll explain why I got to that localization as the best fit. And that's what neurological localization often is, the best fit. Well, first of all, the dog was obtunded. So this told me that there was a lesion, so I meant depressed or stuporous are other words that we can use to describe it, but the most correct word that we use now is obtunded. So this means there's a lesion of the ascending reticular activating system. That's the system that starts in the brainstem and wakes the cortex up. So that doesn't really help us. It could be forebrain versus brainstem. Obviously, it rules out other brain center, the cerebellum, puts that right out the picture. We've got circling to the right. That's a sign that tells us there is definitely a right-sided lesion. So we know that there is a problem on the right. And it comes down to, is it circling because of a forebrain lesion or a vestibular lesion? Well, the character of this circling was much more typical of forebrain, with that tight circling and well coordinated, and with no other vestibular signs. Again, if you're not clear on why that is, then I suggest you check out my circling video. So that makes right forebrain most likely. Okay, then we have left visual deficits which were contralateral to the circling. Again, that supports a right forebrain lesion because we have decussation of that visual pathway. And then we have left visual deficits and an abnormal PLR, the swinging flashlight test. So that means left optic tract nerve versus right optic tract. And as I've said before, because we are already looking at a right forebrain lesion, this makes the right optic tract fit that better, especially as tight circling, in my experience, is often associated with thalamic lesions, and the optic tract is going to the thalamus. So that is my best fit for that. But I don't have an explanation with that localization for the right postural deficits, because if it was a right forebrain lesion, I would expect left postural deficits, again because of the decussation. So this would suggest a right spinal cord, right brainstem, or left forebrain lesion. So I've got two possible lesions, which means it's multifocal, including the right forebrain. That's a kind of given. The right optic tract lesion is the best fit, but I can't rule out a left optic nerve because we've now said it's multifocal, so it could be in a variety of different places. There must be something else which explains the right postural deficits. So we did an MRI scan on this dog, and this is one of the mid-sagittal lesion here. Mid-sagittal images here, and we can see that because it's a Yorkshire Terrier, it does have a degree of Chiari malformation. This is a very short supraoccipital bone. Supraoccipital bone is missing here, as typical with Yorkshire Terriers and Chihuahuas as well. So we've got a little bit of CSF behind the cerebellum there, as this is bulging out with just a membrane here. We do have some high signal in the spinal cord that is almost certainly some syringomyelia, but could also be inflammatory change, especially as we see high signal here and a little bit here. And we have big ventricles in this dog, but there was more. That is really getting the incidental findings out the way. The main problem can be seen here. So we have this very hyperintense lesion in the caudal thalamus, in the area of the right geniculate nucleus of the thalamus, and also extending down to the right colliculus, right midbrain area really, and also involving the right optic tract. And this is it in cross section here on T2 weighted images and on FLAIR images. FLAIR you can think of as highly T2 weighted images, but they remove the signal, shall we say, in very simple terms. It removes the signal from the CSF, the cerebral spinal fluid. So we are taking away the signal here that we can see from the cerebral spinal fluid here in the ventricular system, and also in the subarachnoid space, and all of the white that is left represents static fluid, and it's very useful for seeing subtle lesions. So when we take the signal away from the CSF in the ventricles, we can see that there is periventricular hyperintensity here, and also hyperintensity around around the cortex in the area of the subarachnoid space, suggesting a meningitis process, and also a high signal here, but a very large lesion in this area. And likewise a little bit more rostral, we can see that there was quite a high signal in the left corona radiata. Should be said, this is right, this is left. And I think that some of that high signal in the spinal cord is likely to be inflammation rather than just syringomyelia. But there were importantly no obvious lesions in the optic nerves. Now, some of you, like I did, may be thinking that's quite caudal for the optic tracts, that you may have been expecting it to sort of be a little bit more rostral than that, and could we actually be affecting the pretectal nucleus or a rostral colliculus and PLR? Well, that doesn't really explain the visual deficit, but that's why I really love this paper, going back to it again, and it's open access, so I feel that means that I can show you the lovely images, but I really would commend you to pull this paper for yourself, because we can see how beautifully here that how this pathway here, and this is the optic tract, which is highlighted here, and here we can see that it's going up to this area of the lateral geniculate nucleus, which is corresponding with our dog's lesions quite nicely. So we did a CSF analysis in our guy, and we found that the CSF protein was taken from a lumbar puncture because of the Chiari malformation and the syringomyelia. So this is normal for a lumbar puncture. A little bit of contamination, quite common in lumbar punctures. A mild elevation of the white blood cells, and we saw a mononuclear pleocytosis there. It was negative for infectious diseases. And so the working diagnosis in this guy was a meningoencephalomyelitis of unknown origin, or an MUO. And this is a big umbrella term for a number of different diseases which are actually diagnosed on post-mortem, which isn't a lot of good for most of our dogs. So the big names correspond to the appearance that you see underneath the microscope. So granulomatous meningoencephalomyelitis is associated with granuloma type lesions. Necrotizing, well, it stands to reason that's associated with necrotic lesions. Necrotizing leukoencephalitis is more involving the white matter, and interestingly, sometimes we see breed association with that, and it's been referred to as Yorkshire Terrier encephalitis in Yorkshire Terriers, and of course we have a Yorkshire Terrier there. Eosinophilic meningoencephalomyelitis is characterized by eosinophils. So we don't understand the etiology of this disease, but it's an inflammatory non-infectious disease. It's thought to be autoimmune, maybe triggered by infection, or in my experience it's often associated with gastrointestinal disease and inflammatory gastrointestinal disease in particular. These are the descriptions of that pathology, and this is thanks to Nicola Parry as an example of granulomatous meningoencephalomyelitis. And as a basic summary, wherever you see pink there, that's brain or brain stem, but wherever you see blue, that is all inflammatory cells that is going through that tissue. So this guy was treated, and treatment has varying success. There's a fairly high relapse rate of about 40% of dogs will have a relapse during treatment. The mainstay of treatment is always prednisolone, but if you just use that, then you're unlikely to be successful. And so other immunosuppressive medications are added, and it's quite variable along with the clinician as to which is used. My favourite is mycophenolate for various reasons, but the most popular one is cytarabine. There are other experimental treatments used, but that is not as wide. So this guy was treated and at least did well for a while. I thank his caregiver for allowing his images to be used in teaching. He's quite an old case now. It was more than a decade ago. And thank you all for listening, and to Nikki Parry for those images.